Hi guys, good afternoon. How is your treating you guys?
Amazing. الحمد لله.
إن شاء الله أنتم مع مجركم أنتم عم تدرسوا the heart. بس إن شاء الله we'll try to help you guys as much as possible. So, hi everyone, my name is Joud. Alassaf, I'm going to be giving you guys anatomy for now. We're going to be explaining week 1 and week 2 content. So, first 2 lectures will be the thoracic wall. So for me actually when I first studied the lecture it was such like a nightmare, I remember, because it was very long and very kind of difficult. But because the heart is so important, we need something that protects it, right? So we have the rib cage here that does this job. So first we need some general info on the rib cage. So how many ribs do we have? 12. Okay, so and then are they all the same or is there a difference between them?
There is difference.
Okay, how many types of ribs do we have? 3. What are they? صح. بعدين later on we have typical and atypical, but for now we're gonna divide them into true, false, and floating, right? So based on what do we do that? So true means they directly connect to the, what is this called? Sternum, right. So they directly connect to the sternum. What are the numbers of the true ribs? 7. The first 7. They automatically and directly connect. You can see there's a direct connection to the sternum. And then the false ribs, false because they don't directly connect, but they indirectly connect by connecting to the upper rib, right? Anyways, and then we have the 11th and the 12th. These are called floating because they're floating, literally. They're not connected to anything. So yeah, I think that's it for now. We have the 12 ribs from the front, from behind. We have the manubrium, the body, the xiphoid process. We'll go into detail later on. But yeah, for now that's it. So now we're going to divide them into typical and atypical ribs. Typical, they are from the 3rd to the 9th. They're all typical. What do we mean by typical? So first we're going to start from the behind or the posterior of the rib, and then we're going to see all the features going to the front, okay? So as you can see here, we have a rib, right? So how can I tell which one is posterior, which one is anterior? By the head. So the head, or the head of the posterior part, is rounded. You can see it's rounded, okay? If you think about it, everything makes sense in anatomy because you can see that the vertebra is kind of rounded, so I need the head to be rounded too for it to connect from posteriorly, right? However, anteriorly we have the sternum, it's kind of a flat bone, so we need a flat other end of the bone for it to connect. What else? So we have from the posterior side, this is called the head, and then right next to it is the neck, and then we have a tubercle here. You can see it's very obvious, it's a protrusion, you can say. And it's rough. And then we have the angle. So first, before, I used to think that where it folds, this is the angle, but that's wrong because you can see here, even when you hold the rib in the lab, you can see if you touch it, where it turns, the angle, there is an angle where it goes around. So this is the angle. You can see here how it folds here, okay? And then what else? Yeah, we have this the whole thing. This we call the shaft. Okay, and in the shaft, in the mid part and inferior part of the shaft, we have the costal groove. What goes in the costal groove? Yeah, the neurovasculature basically of the intercostal neurovasculature, right? And then yeah, we have the anterior articulation. So here, just I want to add something that the tubercle actually has 2 parts. We have an articulating part or articular facet and a non-articulating part. The articulating part articulates with what?
Costal transverse.
Yeah, the transverse process of the vertebra. And then what about the other one?
Attachment for the ligaments.
Yeah. Sorry, no.
It's not attachment. The non-articular part.
Yeah, the non-articular part actually connects to the costotransverse ligament. Okay, and then the articular part to the it creates the costotransverse joint by connecting to the transverse process. Yeah, and then also here you can see we have in the posterior head we have 2 demi-facets. Why do we call them demi-facets? Not just facets. Yeah, because they're half joints basically. So here there will be like, here there will be a vertebra, and then here there will be a vertebra. So the upper one will be the higher number. Like for example, if we say this is the 7th rib, the upper vertebra will be the the 6th, and then the lower one will be the 7th connecting. Okay, and like the connection will be directly at the intervertebral disc. So just a part of the a lower part of the upper vertebra and the upper part of the lower vertebra, if that makes sense. Yeah, I think that's it. And then the neck is an attachment for some ligaments. Okay. You can see here how this is the costovertebral joint, like the main connection between the rib and the vertebra. And then we have another one, the costotransverse, between the tubercle and the transverse process. Make sense?
Yes.
Okay, now we're going to discuss the shaft of a typical rib. It will be twisted because the rib has to go around, right? So it's going to be twisted. And then how do I know like which side is the upper and which side is the lower, or the border, which side is the upper border, which one is the lower? It's like a knife. You know how a knife is sharp from below and then blunt from the upper side? It's the same thing. The superior border or the upper border is blunt, or you can say rounded, and then the lower border is actually sharp, okay? And then how do we remember the costal groove where it lies? It's like, you know how the knife shines from below the sharp side? So here you can imagine a line where this is like in the middle lower part. This is the costal groove. So let's go back. We finished the shaft. The angle where I showed you is the weakest point. So this is the most common place for a rib to fracture because it's very weak, so it's very easily broken. And then we have the costal groove, as I said, the location, and then what it contains, I said the neurovasculature, but in what order exactly? The vein, artery, and the nerve. You can remember it as vein, okay? From superior to inferior, okay? Okay, so, yeah, you can see here in the picture also how the vein, artery, nerve, okay? So now we're going to discuss the atypical ribs, okay? So this is a great summary, actually. You can just study this and that's it. But this is a very high yield topic, guys. You need to really memorize it because they love asking about which of these ribs has this characteristic, blah, 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 okay? So how do we memorize? First we said that the 1st, 2nd, 10th, and 11th, and 12th will be the only atypical ribs, okay? So first, for the head, how is it different from the original one? We said the original or the typical one has 2 demifacets, right? Here, the 1st and 10th, 11th, and 12th all only have 1. However, the second one has 2, which is, you can say kind of similar to the typical, but you will see that there are other differences. But how you remember it? Second 2 has 2 heads, okay? Important. And then the neck. Of course, it exists in all of them, except you will notice that the 11th and the 12th rib don't have many things. Why? Because they're floating and they're very short, so there's no point of having all these characteristics. So they don't have a neck, they don't have a tubercle, and then for the angle or the twist, only the 11th, because it's slightly longer, it's just slightly twisted, but the 12th doesn't twist at all. And then, what else? The neck we finished. The tubercle, of course, it exists in all of them, as we said, except the 11th and the 12th. And then the angle, just one thing, that the second is not twisted. Why is that? Do you know why, or can you imagine why?
Is it because of the tuberosity for the serratus anterior when it's not rotated?
So the first rib actually is a very different, how do I say this? Plane than the other ribs. So it's literally like this almost, okay? And then the second one comes slanted, and then the third and then ongoing, they're gonna be like this, okay? So the second one is not twisted because of how its plane is. It's in between, so there's really no need. It's already kind of slanted, if that makes sense. So this is how you memorize it, I guess. And then what else? Yeah, and then the first rib, because it's so short, the angle and the tubercle are in the same place. So where the tubercle is, the angle is. This is where it falls to turn around. Okay. And then the thing, as I said, this is horizontal, this is like oblique, and then this goes like vertical, and then the rest also go vertical. Okay. And then the costal groove, of course, it's all, in all of them except the 11th and the 12th. And the 11th slightly longer, so it's there is a slight costal groove, but it's not really important. Okay, so extra stuff. This is also important. They like to ask about this stuff. So the first rib, the most important things I want you to memorize is the, like you said, the muscles that like attach to each rib. So we have the scalene tubercle at the inner border. I'll show you a picture in just a second. And then the scalene ridge in the upper border, like the scalene muscle with the first rib, and then the subclavian artery and veins ribs. Here there's serratus anterior tuberosity also, like the serratus anterior has a digit that attaches at the second rib. Now, how do I memorize? Because I remember I used to confuse the serratus and the scalene tubercle. I mean, it's very like similar names. So I used to memorize it as the first has the letter C, because the letter C comes before the letter E. So the scalene is with the first rib, the serratus with the second rib. And then yeah, you know that these are pointed and they're short. Okay, so the first rib, let's take a look. So as you can see, it's very short. It's very like rounded. As you can see, it's like almost flat. It's horizontal. You can see here the angle like is exactly where the tubercle is. You can see here this is where the scalene tubercle is. So this is where the scalene muscle attaches. I want to show you here. You can see where the subclavian artery and vein, and then in between them you have the anterior scalene, and then like behind them you have the scalenus minimus and the middle scalene, like the other ones there. Okay. What else? Yeah, you can. This is now the second rib. You can see how the serratus anterior has many digits, and one of them is at the second rib there. Okay, so you can see here the serratus anterior attaches here. Okay, so listen. Really, my only advice about anatomy is that it's all about imagination. You have to draw an imagination like of the organ in your brain, so that whenever you go to the exam and then any question comes along, you know how to answer. Now, 11th and 12th rib, they are abnormal ribs. We have the cervical rib first. It articulates. So, do you know what a cervical rib means? An extra rib, yeah. Before the first rib comes from which vertebra? T1. So the cervical rib would come from C7. It would come like above it. So which nervous structure would it press on? Brachial plexus. No. But that's not like always the case. Might be. And then you can see here how the 11th and the 12th rib are short. The 11th is slightly longer. That's why it has an angle. No tuberosity, no neck, no anything, and also a single articulator. And then the lumbar rib, just skip it. Okay, now the sternum. The sternum we have, as you can see, the manubrium, we have the body, we have the xiphoid process, and then here we have, what is this called? Jugular notch. And then we have here, it connects with the clavicles, so, and then we have where each part connects. So the most important part of the sternum is where the second rib joins between the manubrium and the body, or the articulation between the manubrium and the body. What do you call that? Yeah, sternal angle over angle of Lewis. Yeah. Why? Because we can palpate it, and so we can tell that here lies the second rib, so we can count downward from that. What else? Yeah, also very important, like memorize where the ribs lie, like compared to the vertebra. Like for example here, how the jugular notch is directly at T2, and then the sternal angle of Lewis at T4. But it connects to which rib? Second rib. It's where the articulation of the second rib, but it's at the level of T4. What else? Also, you need to know the types of joints in each one. So here, you know the clavicular notch, but here, this is primary, which is synchondrosis, and then here are secondary, which are symphysis. How do you remember? Just know that like in the midline, they're all secondary, and then on the sides, only the first rib is primary, and then the rest, what are these? They are synovial joints, okay? Yeah, what else? The civiosternal joint is level with, okay, so here, this civiosternal joint, you know that it's like right where the diaphragm lies, okay, and then the inferior border of the heart, because the heart like above the diaphragm, then what is below? The liver, okay? And then, yeah, the default process also calcifies after the age of 40 years, so it creates a hard lump in the epigastrium. Yeah, also the inferior angle of the scapula lies where the seventh rib is, okay? Yeah, you can see here how the diaphragm, then there's the heart, and then there's the articulation between the xiphoid process and the body of the sternum. Central terminal diaphragm. Okay. Now, can you tell me, like, this is not really high yield, but I wanted to see like how much you understand the lecture. So, as you can see here, this is just a normal X-ray of the chest. Do you see these like calcifications, you could say? Do you know what are these shadows? Like, I already gave you half the answer, but the calcifications of what? This is an outpatient. Yeah, صح, yeah. So here the cartilage actually calcifies after a certain age, I think above 40 or something. So this is actually normal, it's fine, but it does like hinder a bit of the mobility of the synovial joints. Why do they happen? Because of just age. Okay. Now, first question, يلا who wants to read? Okay. يلا you read.
Okay. During an anatomy spotter, a student is asked, this rib articulates with the bodies of two adjacent vertebrae. Which rib was he talking about? Okay.
I don't think it's
So it's a typical rib, because it has two vertebrae.
well, شوفي options.
Bodies of two.
هدول typical ولا atypical?
They're all articulate.
Yeah. Okay. Which one of them I told you? No. This is similar to the typical.
Second.
Yes. Exactly. So second is the answer. By the way, please, go back to my slides and check out the questions. Okay. A trauma CT shows a rib fracture exactly where it meets the transverse processes of its vertebra. Which rib part is fractured? Tubercle? Why؟ ليش مو angle؟ أنا مو قلت already إنه يعني الangle is the weakest point.
Which it says meets the transverse process.
صح, bravo. That was a trick question because يعني don't be like me basically. Speaking from experience. Question 3. Anyone wants to read? Or should I read it? Yeah.
A 22-year-old man is found to have a cervical rib anomaly on chest X-ray. To confirm the diagnosis, the physician compares the features of the first rib with the other ribs. Which of the following is the characteristics of the features of the first rib? A. Costally groove for the intercostal nerve and vessels. B. Depression for this. B.
صح, bravo. شطورة. Okay, now we're going to go to the vertebra. This is basically where we go into the second lecture of the thoracic wall. So how we now need to identify the difference between a typical vertebra and an atypical vertebra. So now from the second to the eighth thoracic vertebra, these are typical. Now if you can correlate it, هدي كانوا من أي number لأي number they are typical?
Atypical.
Typical. From 3 to 7? Yes, 3 to 7? 3 to 8?
All except 10.
3 to 8, sorry. لا, 3 to 9, sorry, 3 to 9, I'm sorry. Okay, so 3 to 9. So if you think about it, إنه ليش يعني second to 8, 3 to 9 يعني لأنه where it connects. عرفتوا يعني the typical rib attaches to the typical vertebra, basically. Okay, so we have the body. It's gonna be heart shaped, as you can see, with two demifacets for the articulation. With the head of the ribs, يعني it has two demifacets for the rib that attaches has to have the two demifacets, right? And then the transverse process, there should be a transverse process where it has the costal facets for the articulation of the tubercles of the ribs. And then the spinous process are long, tapered, and slanting inferiorly. You're going to see here, you can see here how it's like slanting a bit inferiorly. And then the vertebral canal is circular, as you can see already. Okay. Now, atypical thoracic vertebra. What's the difference between what we just explained and the atypical thoracic vertebra? So I made this like table. So the first and then 9, 10, 11, and 12 are all atypical. First you check the body facets. Okay, the facets in the body where it articulates with what? The ribs, yeah, but like the head or the tubercle? The head. So here you can see that T1 actually has 1.5. Like usually you either have 2 halves or just one full one. The only one that has 1.5 is T1. Why? Why do you think is that? Yes, لأنه the first rib has one facet صح؟ بس one facet because it joins the first vertebra صح؟ يعني ال T1 later it has one facet صح؟ وهون it joins the first rib. Now why this half?
The other rib?
Yeah, the second is typical صح؟ فit has the demi facet فلازم إنه هون يكون demi facet للsecond rib and then it has a full facet for the first rib. Make sense?
Yes.
Okay, and then T9 actually has only half. Can you think why that is? إنه ليش half ليش مو like a full one?
For the head of the ninth rib?
For the head of the ninth rib. Yes, bravo صح. لأنه شوفي this is the ninth. Only the head of the ninth rib connects here. بعدين لما قلنا 10 11 و 12 if you remember they have only one head facet. Like they only articulate with their corresponding vertebra. So here you can see the 10th vertebra, the 10th rib, on the 11th rib, on the 12th rib. So the 9th has only the half demifacet, and then the other half of the demifacet بأي vertebra around 9th rib? 8. Okay? And then مثل ما فرجيتكم هلا they only have one. Transverse facets طبعا they're present in all except 11 و 12. ليش؟ لأنه no tubercle. صح؟ بال 11th و 12th rib we said no tubercle. And then sinus processes, here we have, actually with T1 they are horizontal, إذا بتنتبهوا بالspine, when you go down, they're going to be more and more slanting downwards. So that's why the T1 actually has a horizontal spinous process. And then special notes, only the T12 I want to talk about it, the inferior articular facet faces laterally, lumbar type instead of posteriorly. You see this one, the inferior articular process. This one is usually like, you know where how the vertebra like attached to under each other. مو صح كافي عنها هي inferior articular process or superior articular process. Anyways, they're usually facing posteriorly. Okay. Now, when the thoracic meets the lumbar part of the vertebra, it's gonna turn laterally. Yeah, it's gonna turn laterally to join it fits with the lumbar vertebrae. So this is only the 12th. Anyway, intercostal muscles. We have external, internal, and transversus thoracic or innermost intercostal, interchangeable names. As you can see here, we have external, internal, innermost. What else? I want to show you. طيب هلا do you I'm gonna explain more detail. I'm gonna go and then come back to the picture to show you. So we have the external intercostal. Now this is for inspiration. Okay, you're gonna notice this is like among the ones that they focus on in the lecture. This is the only one for inspiration. So like you can make sense of it because the origin is the lower border of the rib above, and then it inserts it on the upper border of the rib below. So it goes from above to downwards, and you can see downwards and forward. So when it contracts, it's gonna like open up the rib cage. That's why it allows you to breathe. Okay, and then comparatively, you can see the internal intercostal. The origin is the costal groove of the rib above. Is this like on the lower rib or the upper rib?
The lower rib.
The lower part or the inferior part of the rib. And then it connects to the upper border of the rib below. صح? It goes downwards and backwards. Like it does the opposite. It like closes up the rib cage. It makes sense. So that's why it allows you to exhale. And then what else? Yeah, the extent you can see here, like how much of the rib cage is it covering. You have the external. It's from the tubercle, from behind until the costochondral junction. Continues as the internal intercostal membrane. So in the costochondral junction, it stops as a muscle and then continues as just a membrane until the midline. Okay. And then for the internal intercostal, always compare them so you don't mix them up in the exam. It goes from the sternum until the rib angle and then continues as the posterior intercostal membrane. Okay. Nerve supply, they're all supplied by the intercostal nerves. And then the actions, see here, it elevates the ribs, here it depresses the ribs. Now for these three, we have first the sternocostalis, autoanthosis thoracis. I think I have a picture. I think this is just the innermost, like where is it? This one. Okay, the inner layer. So this one actually, the origin is from the lower third of the sternum. It goes to the costal cartilages, upward and laterally, also supports the sternocostal joint. And then intercostalis, or in the innermost, right? This is the innermost. Lower border of rib above, and then attaches to the upper border of the rib below. Do you know like which, is it similar to which muscle?
First one?
Sorry?
The first one.
Yeah, I think it's similar to the internal because in the lower part of the rib to the upper part it goes downwards and backwards. See, this one also goes downwards and backwards. And then middle to fourth, so it covers only the middle to fourths of the rib. And then also same function, depresses the ribs, allows for expiration. So this is very similar actually to the internal one. Okay. And then subcostalis. So first the sternocostalis. I want to show you. This is the sternocostalis. See how it like supports the attachment of the ribs to the sternum. And then here for the subcostal muscles, you can see like they're literally called subcostal muscles. So they attach like from rib to rib to rib to rib like this. Okay. Anyways, now we're gonna discuss the internal thoracic or mammary artery. First, the first part of the subclavian artery. So you can see here the subclavian artery. The first part of it comes a branch. We call this the internal thoracic artery. Okay. Now the course, it descends behind the clavicle. You can see here, like the clavicle, it goes behind it. Okay. And then also goes behind the first costal cartilage. So here we have the clavicle, the first rib, it goes behind them both. And then down to the sixth intercostal space. Like this is important because sometimes they'll tell you, oh, this person got hurt like on this point of the body like this, so you need to know like how it runs in the body. And then down to the sixth intercostal space. Keep going down until the sixth intercostal space, and then what happens? It branches. First, it gives the pericardiophrenic nerve. So the pericardiophrenic, as you can see, comes from the very beginning. And do you know where it goes? It's like mentioned in the future lecture, but maybe you focus on the lecture or something, or you studied it. The pericardiophrenic nerve. Artery, sorry. And nerve. Yes. Anyway, and then we have the anterior intercostal, two for each of the upper six spaces. So you can see here the anterior intercostal arteries. Okay, so you need to also remember this because later on we're going to discuss the intercostal arteries where there is an anterior one, a posterior one, and then the anastomose. Okay, so here comes the anterior intercostal arteries for which ribs, only for the upper six spaces. Okay, the lower six spaces, technically 5 spaces, we're going to see later. Anyways, and then the perforating, especially the second and the fourth, they go to the mammary gland of the breast, I think. And then muscular phrenic, as you can see here, the muscular phrenic, this one, okay. And then lastly, the superior epigastric, here, this one, okay. Yeah, I think that's it. And this is a mnemonic. Patients always promotes mindful success for you to remember the main branches. Internal thoracic vein, I'm just going to go through it very quickly. So the origin is behind the third costal cartilage. So actually you need to remember this one, that the artery ends at the sixth intercostal, it branches in the sixth intercostal cartilage. And then this one starts from the third, يعني في space where it's only artery and there's no vein. صح؟ Okay, يعني لنفس الاسم قصدي internal thoracic vein. So this starts from behind the third costal cartilage. Termination drains into the brachiocephalic vein. You can see here, this is the subclavian, okay, and then this is the jugular, and then they both go into where? Into the brachiocephalic, صح? And then you can see that the هذا هو the internal thoracic, this one, the left internal thoracic, it will join with the brachiocephalic, okay? Tributaries correspond to arterial branches, they have the same branches basically.
Can you repeat the internal thoracic veins?
Sorry, no. Mafi, it just starts from the third costal cartilage, okay? Termination drains into the brachiocephalic. Do you see the brachiocephalic? This one, okay? وبعدين هي الانترنال في إلها 3 tributaries, 3 things that empty into the brachiocephalic vein. عندنا the jugular vein, we have the subclavian vein, like jugular vein, subclavian vein, and then you can see this one, the small one, the right internal thoracic vein. Okay, sounds good? Okay, and then intercostal arteries. As I told you before, that you can see here the anterior from the internal thoracic artery comes the anterior intercostal arteries, and then they anastomose with the posterior parts. Okay, so from the anterior, I told you the upper 6 from the anterior thoracic, صح? Now the lower from the musculophrenic, which is a branch of internal thoracic, صح? So it's just like a different name, but it's basically the same artery. It's just because after the 6th we said it becomes the musculophrenic. And then the anastomose with the posterior intercostal arteries. Now the posterior, where they come from? Oh, by the way, the anterior, we actually have per space, we have 2 arteries running. However, in the back, we only have 1 artery running in each space, okay? So we have first and second, like the first and second spaces, they are actually from the superior intercostal or the costal cervical trunk. However, the 3rd and the 11th, they come from the descending thoracic aorta, how the aorta goes downwards like this. So from the descending thoracic aorta, and then the right side is longer than the left. Why? Because it goes slightly to the left, right? The aorta, if you remember, it goes like this and then descends slightly to the left. That's why the right, when it has to go to the aorta, they are longer. Make sense? You can see here actually. This is like the left side, so it's to the left. That's why the right, when they want to attach or actually technically come out, they are longer. Yeah, as you can see here, anteriorly we have 2 per space, and then posteriorly we actually have only 1. But to make up for it, to be able to anastomose, they give another branch, so they can the two cannot anastomose with 1, right? So we give from the 1, we give another branch for them to anastomose. But for what you need to remember is that 2 from the anterior and then the posterior, we only have 1 running, okay? Intercostal veins, all you need to know is that how they drain. So just that the posterior azygous and hemiazygous veins, and then the anterior drain into the internal thoracic vein. Just remember it because the internal thoracic actually is more anteriorly, anatomically is more anterior, and then the posterior is the azygous and hemiazygous run more posteriorly. You can focus more on the picture later, but you can see here that it's more anterior, and then the azygous and hemiazygous run more in the back. Intercostal nerves. So intercostal nerves, actually all you need to know, you can not really focus on it honestly, but for the sake of the lecture, origin, ventral vermi of the thoracic spinal nerves, how many are they? They are 11 plus 1 subcostal, because you remember we have 11 spaces, right? So the last one, the 12th one, actually does not run in an intercostal space because we don't have a 12th intercostal space. So we call it the subcostal. It's right under the rib. Now types, we have typical and atypical again. The typical from T3 to T6, why are they typical? Because they supply just the chest wall. Because they're intercostal nerves, so if they supply just the chest, this is T3 to T6. Atypical, we have T1, T2, and then the lower 5. So the first 2 and the lower 5. The first 2 contributes to the brachial plexus. This is the first one. Why is it atypical? Because it contributes to the brachial plexus. T2, intercostal brachial nerve. It contributes to the axilla and the arm. The lower 5 continue into the abdomen. So that's why they are atypical, because they supply other areas other than the chest wall. Make sense, guys? Okay. Dermatomes and herpes, also again very simple. The main part you need to know is that here, like from the angle above, this is from the jugular notch above. This is the sternal angle. I'm sorry. From the sternal angle above, this is C4. Below it is T2, and then like you continue. Now the rest, where do they go? The in between the C4 and the T2, from C5 to T1. Brachial plexus, right? You remember they go into the arm. Now herpes zoster, it's just a reactivation in spinal nerve roots of the virus reactivates in the spinal nerve roots, and it's a very painful rash along the dermatoid that it affects. Now the diaphragm, also an easy topic. The origin is from the lower 6 ribs, the xiphoid process, the L1, L3 crura. You see here the crura, these are the crura, and then we have the arcuate ligaments too. Anyways, it's not. Insertion, they insert into the central tendon, so it actually like comes from all around and then comes and inserts in the central tendon in the middle. Okay. What is the innervation? It's the phrenic nerve. Goes from C3 to C5. Now we have 3 openings. Okay, a great mnemonic you have to remember for the rest of your life is it's gonna come up a lot. I8, 10 eggs at 12. So I8, so I is for the inferior vena cava, and then it opens at the level of T8. And then we have 10x, so T10, E for esophagus, so this is the opening for the esophagus at the level of T10. And then the opening for the aorta is at T12. Makes sense, guys? You can see here, this is where the esophagus opens, this is the inferior vena cava, esophagus, and then the aorta. Of course, it's the main muscle for aspiration and abdominal straining, and helps in venous return. So now, for phrenic nerve palsy, it's just a paradoxical elevation of one hemidiaphragm on aspiration. So you can see here, basically the left phrenic nerve is not innervating the dome anymore. So that's why it like relaxes, so it goes up a lot, and also the organs push it up. So you can see here how it's like way higher because the stomach is like pushing up on it, so you can know that this is our left phrenic nerve palsy. And then the thoracic wall movements and breathing, just like take a look honestly, and they're not that important, but there might be a question, I never know. We have vertical, AP diameter, and lateral diameter, like how these diameters change when breathing. So the vertical, the diaphragm when it contracts, we have inspiration, then it relaxes in expiration. So as you can see here, the vertical is this one. So as you can see, when it breathes, like it goes like it changes vertically, right? Now the AP diameter, pump handle. So this one, how the AP diameters change. So like you can see, this is the anterior posterior. So it like raises above and then comes back down. When you breathe, you see that already. And then we have the lateral diameter, also the same thing. It's a bucket handle movement because the ribs will like be like pulled up, so by the muscles, so it's gonna go up and then come down while expiration. Now, our third lecture, I love the anatomy of the heart. I bet it must have been so fun going to the OSP lab. So the external anatomy, the heart, it looks like a cone shape, right? So we have first an apex of the cone, right? And then we have a base. And then we have an inferior border and then a superior border. And then also we have like surfaces. But first let's go like one by one. So as you can see here, the apex of the heart, you know like how it goes like to the left side, a little anterior, and then a little to the left. So where is the apex of the heart exactly on your body? Because it's very important. So you're gonna use it a lot like moving forward. Okay, so this is the apex of the heart. And then we have the left border. This is the left border of the heart. You can see mainly it's made by what? Left ventricle. And then, yeah, this is mainly the thing you need to know about the left border. And then we have the upper border. You can see here it's a bit hidden by what? By the pulmonary trunk and the aorta and the superior vena cava, right? So, but this is where it is basically. And then here, the right border, you can see it's in between the opening for the superior vena cava and the opening for the inferior vena cava. So this area exactly. So it's of course just the right atrium. And then we have the inferior border, mainly by the right ventricle. What else? I think that's it for now. Okay, so now this is from behind. Now, how can I tell if this is the base or the diaphragmatic surface? How you can tell is basically there's this coronary sulcus. This is where it like separates the base from the diaphragmatic surface. Also, the heart is like sitting like this. So this is the diaphragm. It sits here. This is the diaphragmatic surface, and then this side is the base. Okay, where it's like posterior. So the posterior surface, the base, it's mainly of course by the left atrium, and then it sits or like it pushes or like in the middle. What do you find behind it exactly? You find the two right pulmonary veins. Okay, and then two more things. What are they? What is right behind the heart? Two things. The esophagus and the
Descending aorta.
descending aorta. Okay, so you have three things again behind the base of the heart. We have the two right pulmonary veins. We have the esophagus, and then we have the descending aorta. What else? Oh, also the levels are very important. You can see here it starts at T5 and then ends at T8. You can see here it sits on the diaphragm. This is the central tendon, so it kind of like goes to the left a bit, to the left scapula. I think that's the most important things. Now the base posterior relations, as you can see, as I just said, here you have the right pulmonary veins, and then you also have here, you can see here, this is the esophagus comes first, and then the descending aorta. Now, so the left phrenic, also there's the left phrenic nerve and pericardiophrenec artery and vein on the left and right surfaces. Do you know like how to differentiate between a surface and a border? Okay, so in every lecture there's like right border, and then right surface, left surface. They're basically the same. It's just that the border is like a line, but the surface is the whole area, right? So when it says surface, think of like arteries and neurovasculature like this, because like I'm covering a whole surface, so of course some things will be running there, right? So for the left and right surfaces, we're gonna have the left phrenic nerve and the pericardiophrenec artery and vein. Now, do you remember which artery it comes from? I just said it. Pericardiophrenec. Internal thoracic, yeah. Okay, so one like the first branch that comes from there. Okay, so it goes and supplies the pericardium and the outside of the heart. So here you can see also the fibrous pericardium is at the surface. Yeah. And then groups of the heart. We have the atrioventricular coronary groove. The picture is very bad. But the atrioventricular coronary groove is basically where it separates the atriums from the ventricles. This is the coronary groove. What runs in it? The coronary?
The coronary sulcus.
Sinus.
Sinus.
What runs in it, I mean. And then the interatrial groove, of course, the groove that separates the two atria from each other. We have the anterior interventricular groove and the posterior interventricular groove. So we have two grooves separating the ventricles of the heart, to right and left. The anterior one, it's on the sternocostal surface. Anterior, right? Contains anterior interventricular artery and great cardiac vein. And then we have the posterior interventricular groove on the diaphragmatic surface, right? From below. Contains posterior interventricular artery and middle cardiac vein. Yeah, that's it. And then the fibrous pericardium, it's a strong outer layer. It's non-stretchable. It's like to anchor the heart in place, so it has to be very strong. So it fuses superiorly with walls of the great vessels, because you can see the heart has the aorta and the pulmonary trunk, blah blah blah, coming from outside. So it fuses like superiorly together, and then inferiorly with the central tendon of the diaphragm. So it fuses with the arteries from above, and then from the central tendon of the diaphragm from below. And then anteriorly, it connects to the sternum. Okay? So it anchors the heart to the great vessels, to the diaphragm, and then anteriorly to the sternum. How does it anchor to the sternum? Via sternopericardial ligament. You can see it here. Here, the sternopericardial ligament are these. Okay. Yeah, and it prevents the heart from overfilling. Now the serous pericardium, the inner one, enclosed within fibrous pericardium, so inside it. Two layers, we have parietal and visceral. The parietal lies the fibrous pericardium, and then the visceral, so the parietal, you know, anything parietal is like outside, anything visceral on the inside. The parietal lies the fibrous pericardium, visceral is the same as the epicardium. So if I say the visceral serous pericardium, if I say the epicardium, it's the same thing. Okay? So this covers the heart surface. It's directly on the heart. Between these two layers, what do we have running?
Pericardial cavity.
Exactly, which has lubricating fluid, right? Or the pericardial fluid. Now, if this pericardial fluid is normally thin, right? Because we can't have too much pressure coming on the heart because of the fluid. Now, if these pericardial layers, if they get inflamed, right, they're going to cause a friction rub. Because they're going to get inflamed and thick, so whenever the heart beats, you're going to have this friction between these two layers, right? And then later on, what happens as a complication, you have pericardial effusion, where the fluid builds up a lot because of the inflammation. Okay, so the fluid will accumulate, and then what will it do? It will put pressure on the heart. Okay? So you can see the symptoms later on. The lecture doesn't go into much detail, but this is just a general idea. Now for the pericardiocentesis, now your patient has pericardial effusion. What do? I need to drain it, right? How do I drain it? Needle insertion to remove the fluid. I have two places where I can take the fluid out. I go just below the sternum, the left costo-xiphoid angle. You can see here, you see this is the xiphoid. On the left side, I'll put a needle right there and then go up until I reach the heart. Okay? And then what else? The other way is the fourth or fifth intercostal space without hurting the pleura, because you can see the pleura of the lung is like here, right? So if I go too far away, like not too close to the sternum, if I go a bit laterally, I might hurt the pleura of the lung. Okay, so you need to go very close to the sternum. Behind the sternum, there is no pleura. Okay, I will reach the heart through that. Yeah, that was a pleura and vessels. You can check out the. Okay. Now for the sinus of the pericardium. We have two sinuses. And when I first studied like this slide with the sinuses, I remember like just memorizing it and not understanding what they mean, honestly, because you can't really imagine what do you mean, like an opening under and an opening behind, like this, you know. So I remember coming across this like surgeon that made this like video. I just took a very small part of it where he shows you the sinuses in real life, like on an actual body. It's very cool. Now, but anyway, let's take a general idea before we see the video. Now we have first the transverse sinus. Okay, it's between the superior vena cava in the front and the aorta also. It's gonna be on the front. From the back would be the pulmonary trunk. I will show you just now. But basically, what's the point of this? Like, how do we use it as surgeons in the future, inshallah? Ligature to clamp the arterial outflow during operations. So I will close, I will like go from behind and like close the flow of the blood so I can work on the heart. Make sense? Anyways, and then oblique sinus, it goes from like right under the heart, you're gonna see in a second, behind the left atrium, between the pulmonary veins and the inferior vena cava. The pulmonary veins, you remember, like goes like directly from behind, and then the inferior vena cava is kind of posterior. Blind-ended space figure cannot pass around. So it's like, you know, like how you have a pouch in your jeans. You know how it's like a pouch, but then it's blind-ended. You cannot go further than that, right? This is basically how the oblique sinus is. It's just like right under the heart. So I'm going to show you the video.
First one is this one, where my hand has gone in. It has gone obliquely up and to the right. This is called the oblique pericardial sinus. This is a dead end. The dead end being formed by the four pulmonary veins and the inferior vena cava and the superior vena cava opening into the heart. This is the oblique pericardial sinus, and this forms the posterior relation of the base of the heart, namely the left is the transverse pericardial sinus, which is surgically very important. And I'm putting my finger in the transverse pericardial sinus right now. And if you notice very carefully, in front of my finger is located the arch of aorta. And ideally, even the pulmonary trunk should be located in front. And behind my finger is located the superior vena cava. So this is referred to as the transverse pericardial sinus. Transverse pericardial sinus embryologically is the remnant of the space between the arterial end of the heart and the venous end of the heart, with the heart tube.
Anyways, so basically this is where you ligate the aorta. Now for nerve supply, as I said before, you already know that we have the phrenic nerve. It actually, like, we have the fibrous and the parietal pericardium and then the visceral pericardium. The visceral is on the inside. The pericardium, اللي هو سميناه نحن anyway pericardium, it's right, صح, okay. And then it's supplied by autonomic nerves. So basically, how does that like help you like recognize? So if the patient has like heart pain, it's possibly on the outer, like the pain coming from the outer surface, from the fibrous and the parietal pericardium, because it's supplied by the phrenic nerve, which gives somatic or pain sensitive, somatic innervation. But the visceral pericardium or the epicardium has vagus or sympathetic nerve, autonomic, so that's why they doesn't feel pain. I just wanted to show you here that's how the vagus nerve, the phrenic nerve here you can see is more like on the outer side, and then the vagus nerve is more on the inner side. Cardiac referred pain, this is actually also important. So it comes why do we have pain in the heart? Because of the ischemia, because the heart isn't getting enough oxygen. So these metabolites will stimulate the sensory nerve. Now the fibers will travel by cardiac sympathetic nerves, enter the spinal cord at T1 to T4. Now when it enters the spinal cord at T1 to T4, this area actually shares the same, like, basically the brain cannot tell, like, is this pain from the heart or is it from the shoulder? Okay, that's why whenever you see like an MI patient, he's gonna say, oh, the pain goes to my left shoulder. Why? Because the spinal cord basically doesn't have like, oh, this is from the heart, this is from the shoulder. They're the same thing, okay? So that's why sometimes it overlaps, they come together. Now, the pain referred to the chest wall, of course, the upper four intercostal nerves. And then the left arm, why? Because via the intercostal brachial nerve, or T2. It also connects with the medial cutaneous nerve of the arm. And then sometimes it goes up to the neck and jaw, but not mostly these two areas, and this is important. Now, question. I'm going to read the question. So, right atrial dilation is seen on echocardiography. Which of the following veins is least likely to drain into the right atrium?
B. No, let me try again.
Don't feel bad, I did the same mistake. Pulmonary veins. Why? Because I remember, I saw Tibesian veins, I was like, what is that? Of course, that's the answer. I've never heard of it. But apparently, it's actually like the same name of, I forgot the other artery, that's the same name. But anyway, it's one of the, like, the small ones.
The empties into the heart.
Yeah, the small vena cava, anyways, these Tibesian veins are the small tiny veins that actually do open into the right atrium. It's just that the pulmonary veins, if you think about it, the pulmonary veins don't open into the right atrium, they open into the left atrium. Okay? So that's why, guys, please read the question a trillion times, please. Now, question 5.
A CT scan shows a mass between the pulmonary veins and the inferior vena cava. This location corresponds to which cardiac structure?
C oblique.
C oblique. Between the pulmonary veins and the inferior vena cava.
No.
It's where you put your finger. So,
Transverse.
Pulmonary veins and inferior vena cava مكان oblique.
Pulmonary trunk and aorta.
هذيك aorta وهيك oblique صح؟
this oblique لازم نسقف لها.
صح؟ أظن oblique. Okay, in the last lecture, I hope I'm not taking too much time. The right atrium. Sorry guys, what nothing is difficult.
لا لا عادي تقدر
Okay,
تسوي.
so right atrium, we have external features, forms the right surface and the border of the heart, we know that already. The right auricle, شو يعني auricle?
اللي يكون عند الاتريوم بس من
Yeah, it's like an extra pouch that like comes over the heart. You can see where is it? This one. You see the auricle? It's like an ear basically here. Okay, at the corner. It overlaps the root of the pulmonary trunk, rough inside, crenated outside. So what I mean by this is that the inside is like rough and then the outside is smooth. The sulcus terminalis, groove outside, the superior vena cava and the inferior vena cava. Do you know what is the difference between sulcus terminalis and then crista terminalis? Okay, so basically, it's a part where I got confused before also when studying the lecture. Sulcus terminalis, it's the same groove, but one is from the outside, one is from the inside. It's just the same thing. The sulcus terminalis is the groove on the outside, in between the superior vena cava and the inferior vena cava. However, when it says crista terminalis, this is the inside of it. Okay? Where can I show you this? This is the crista terminalis, you see? This is because it's from the inside, but from the outside, here in the picture, it doesn't show it.
تحت right
تحت
atrium.
the right atrium?
On the left picture. Not the
Here.
Yes.
Yeah, here? No, here between the superior vena cava and inferior vena cava, I know. صح, sulcus terminalis, bravo, okay, this one. So here's from the outside, here's from the inside. Okay, now from the interior, the anterior, okay, so the anterior, you have to memorize this. The anterior is the rough part. And it's also called the atrium proper because they have different embryological origins. So the anterior is rough, called atrium proper. The posterior is smooth, called sinus binarum. Now this one, why is it rough? Because it contains musculi pectinate, or from the primitive atrium. Whereas these ones, you see how it's rough here? Because it's have here, this one. This is the anterior wall, okay? Now the posterior smooth part, you can see how this is smooth. It doesn't have these pectinae. It receives the superior, so it has what openings? The superior vena cava here, has the inferior vena cava, it has a coronary sinus opening from sinus venosus, and then the rest will come into. And then the septal wall, interatrial septum, divides the left atrium from the right atrium. We have now on the septal wall we have the fossa ovalis and then the fossa ovalis. Limbus fossa ovalis, بس نحن بالlecture anyway it's called fossa ovalis and annulus ovalis. Annulus is the secondary one where it goes above it, and then the depressed part is the fossa ovalis. Okay. I think see here the vena cordis minimis, because I forgot its name. These are the Thebesian veins, if I remember correctly. So you see how like there are tiny openings here for them. This is the septum premium, or also called the fossa ovalis. So if he said like septum premium, he said fossa ovalis, they are the same thing, okay? And then we have the septum secundum. I think you've been going this one all the time. And then openings, I already mentioned most of them. Just remember the levels, guys, please, the levels are very important. Superior vena cava, third costal, inferior vena cava, sixth costal cartilage. So you have third and then sixth. And then the coronary sinus is in between the inferior vena cava and the tricuspid orifice. You can see here the tricuspid orifice, and then this is the inferior vena cava opening. Here is the coronary sinus opening. And then you have the anterior cardiac veins. They are just veins that open directly. And then we have the vena cordis minimi, very small veins open directly also, same thing. Clinical note, the right auricle interior, okay, is spongy. And there is a very high thrombus risk, pulmonary embolism during atrial fibrillation. So if you see atrial fibrillation, there's a thrombus, where is it? At the auricle, at the right atrium, okay? I just wanted to show you here, you see these tiny like opening? This is the vena cordis minimis openings, because they're not really always shown in pictures. Now the left atrium, it lies behind the right atrium, base of the heart, related posteriorly to the esophagus. We already said this, right? That because of the base, we have the esophagus and then we have the descending aorta. Via fibrous pericardium and oblique sinus. So we have the fibrous pericardium, we have the oblique sinus, and then comes the esophagus. Interior, mostly smooth. Auricle has muscular pectinate, we said this already, and the right atrium. This one also has, but mostly smooth, so very little amount. Now, wall is slightly thicker than the right atrium. Why is that? Because we know that the higher pressure causes a thicker wall. Now, the openings, we have the mitral valve orifice. As you can see here, so see, this is the mitral valve orifice. And then we have 4 pulmonary veins that open into it, and then we have the vena cordis again. Okay. Now the right ventricle, we have from the external, it forms again sternocostal surface. I already mentioned this. And then the upper conical part, this like makes the infundibulum or the cons arteriosus. This is below the pulmonary trunk. I have another picture that shows it, but basically it's like just a tube where the blood flows, so we could just call it the infundibulum, okay, or the conus arteriosus. Now interior, we have a rough inflow part. Whenever the blood comes gushing in, it's a rough part, and then when it goes out, this is a smooth part, which we call the infundibulum again. So below supraventricular crest has, okay, the trabecular carne. So again, there's another picture. Trabecular carne, capillary muscles, these are connected via chordae tendineae to the tricuspid cusps. We have muscle, and then we have chordae tendineae, and then they attach to the cusps of the valve. I hope that makes sense, because sometimes they're confused together. And then smooth outflow part, infundibulum pulmonary orifice, separated by supraventricular crest. Guys, I'm taking so long. I'm not expecting that to take this long. Anyways, left ventricle. We know thicker wall, everything, blah blah blah. It's the main part of the show. Upper part under the aorta called the aortic vestibule. Now this is important. Remember that the left ventricle has an aortic vestibule. In the right ventricle, what did we call it? Infundibulum, okay? But they're both basically the smooth outflow part of the ventricle. Now the wall shape, of course, 3 times thicker because of the high pressure. Cross section is circular, as you can see here in this picture. This is circular, this is crescent shaped. And then we have the interventricular septum bulges into the right ventricular cavity because of the thicker wall again. Okay, now the interior. As I said, rough inflow part from the mitral orifice to the apex. Why is it rough? Because of the trabecular carne, which are more numerous than the right ventricle. And then 2 papillary muscles, we have anterior and posterior. You can see here the papillary muscles, these ones. Okay, and then here, see papillary muscle, chordae tendineae, and then it attaches to the cusps of the valve. Now, orifices, we have mitral orifice and valve, aortic orifice and valve, we already know this. Yeah, the question. I think this is the last thing.
Why does the interventricular septum normally bulge towards the right ventricular cavity? Interventricular septum.
Is the right ventricular pressure أكتر من left ventricular pressure? لا.
Left ventricular.
طيب left ventricular wall is 3 times thicker than the right?
It's
Yes,
thicker,
it is.
yeah.
طيب right atrial contraction pulls the septum?
No.
لا. Presence of the moderator band كمان لا.
Sorry.
من the left. فصح. برافو عليكم. بس خلاص.
بس هي moderator band, what is the function?
هلا شوفي هي كان بس بتذكر محطوطة بس بالجدول هذا اللي بالأخير بالlecture. أنا بحس إنه it's really not important بس I remember looking it up before.
They mentioned something distension, بس أنا I didn't get what that means.
It's basically with the electric activity. The moderator band, لما حصل عندك Purkinje fiber, it divides into right and left. The moderator will take the right to the right ventricle, but the left will continue.
بس أنا ما دخلها بالanatomy honestly, so just skip. Okay, yeah, that's it. Thank you guys. I'm sorry for taking too long.
لا عادي شكرا.
Hala, we're going to take a quick break from all the memorization and anatomy. We're going to move to physiology. Physiology is kind of fun if you understand the basics. It's just common sense because it basically has more to do with the mechanics than memorization, but there's a few rules that you have to set. Okay? So we're going to start with the first lecture, which is Introduction to the Cardiovascular System and Hemodynamics. So basically, at rest, now as you guys are sitting, there's a general rule that says the venous return equals the cardiac output, meaning whatever your heart is going to receive, it's going to pump. It's absolutely common sense because the heart is not going to take the blood anywhere else. But in order for us to move any fluid from one place to another, what do we need? Pressure. We need a pressure gradient, and it's gonna move from where to where?
High to
From high to low. Exactly. That's what happens around the body. And then we have two systems. We have the pulmonary system, and then we have the normal system that the blood is going to be sent to. Now, which one do you think has a higher resistance?
Systemic.
The systematic. And then the pulmonary is lesser. Do you guys know why? Because the pulmonary is a closer proximity. Yani the lungs and the heart are in the same cavity, which is basically within the thoracic wall. You need to produce less pressure gradients to move something that's closer compared to moving the brain, to the kidney, and to something like to anywhere else. This small table I've added, it's from the BNB video. It's very helpful. It basically shows you that both of these circulations start with the cardiac output at their flow, but they end into two different, the beginning is going to be different and the end is going to be different. In the lungs, it starts from the pulmonary arteries, ends in the left atrium, while in the body it starts with the aorta and then terminates into the right atrium. Okay, now there's the difference between capacitance and compliance is something that basically a lot of students confuse. But it's simple. Compliance is something that you can stretch. So if something is able to stretch, it's going to accommodate a huge amount of volume. But if something is unable to stretch, you will not be able to hold a big amount of blood if it changes. So basically, if we looked at the formula, compliance is the change in volume over the change in pressure. If you increase the volume, if a vessel was compliant enough, it's going to be able to increase. If it wasn't, it's not going to stretch and the pressure is going to increase. So basically, before I move on, which one do you think is more compliant? The vein or the artery? Because the veins are basically the blood volume reservoir. They keep a huge amount of volume relative to the arteries, where arteries are more concerned with pressure reservoir. They're going to keep the pressure for a longer distance to help move the blood. Now, if we applied what we just spoke about, compliance and capacitance, to the relationship between the transmural pressure. So first, what's the transmural pressure? It's the intravascular pressure minus the extravascular pressure. It's basically, you know when you have a tube and there's something moving through it. So the pressure that the fluid exerts in case blood on the walls is basically the transmural pressure. And since veins are going to be more compliant, if you have something that's able to move, it's going to expand. So if you add more volume in it, it's going to be able to stretch out and accommodate this. And then it's going to move it easily. However, if you try to insert the exact same amount within the artery, because they're not highly stretchable, they're not going to accommodate, which is going to cause a huge amount of change in the pressure. So basically, think about it in this way. You have the artery, it's empty. You insert a small amount of, or the normal amount of blood in it, it's going to stretch to its normal extent to a certain point. After this point, if you try to even add a small amount of volume, because they're not capacitance or they're not compliant, this small amount of volume is going to produce a huge change because they're unable to stretch, so the pressure inside of them is going to increase. But in the veins, it's completely the opposite. You're going to fill them not as much as you want, everything has an extent, but basically because they're compliant, they're going to be able to expand and accommodate. So even if you have a large volume, there's going to be a smaller change in pressure due to their elasticity and able to stretch. In this graph, you could see how if you have this is going to be our x-axis is the pressure and this is the volume. You can see where it comes to the vein, you keep on increasing the volume, but the pressure is not changing rapidly. But when you look at the artery, you have a slight change in the volume, but the pressure is hugely increased. Okay? And then take into consideration what aging has to do with these two. Because as we age, we're more prone to get damage into our arteries and to get atherosclerosis, so that could affect greatly. It will decrease both, but the arteries to a greater extent. Okay? Now, you're going to find a lot of pictures I took from the USMLE book because it basically summarizes the lecture, but in a more like bullet points, and it contains everything. So basically, we're going to start with a formula that says flow is equals to the change in pressure divided by the resistance. If you take this formula, you're able to see how it regulates the pressure, the flow and the resistance. You can manipulate the factors and move them around to see the relationship between both. Okay, then we know that when you increase the pressure, will the flow increase, will it decrease?
Decrease.
No, the Q equals delta P over R. If you have a higher pressure gradient, the flow will increase. But if you increase the resistance,
The flow will decrease.
it's going to be decreased because they're inversely proportional. This is one way you could define the resistance, but there's another law called Pascal's law or Pascal's law, where it basically says that resistance is equal to 8n, which is the viscosity, times length, divided by pi r squared. The 8 and pi are constant, we're not going to look at them. We are going to be left with n, which is the viscosity, length, and the radius. Okay? The length of a vessel does not change. Yes, it can expand, but it's going to be nevertheless the same, so it's also constant. Then you're going to have two major things that you can manipulate. Viscosity, you know what is viscosity? It's basically the amount of red blood cells in something. If something increases, so it became more viscous, it's going to have a higher resistance because it's going to be more slower compared to something that's more liquidy that can move. But the major or the most important is the radius of the vessel. And you can see here that it's related to the fourth power. So if you increase the radius, you're going to decrease the resistance. If you increase the resistance, you're going to decrease the radius, and they're vice versa. But it's very important to keep in mind that it's to the power of 4. So if it doubles, it's going to 16. If it's by half, 1 over 16. Okay? And then you can see here it's also written, there are some cases that might increase the viscosity, such as polycythemia. Decreased viscosity in anemia, the blood is going to flow faster. Now, in addition to these stuff, we can see how the pressure is affected along a different force. So pressure is equals to the force divided by the cross-sectional area. Which vessels have the highest cross-sectional area in the body? Exactly, the capillaries. And is the flow within the capillaries high or low? The speed? Low. Why? Because it needs to serve the function of exchanging the metabolics and giving nutrients, and gaining nutrients, giving off waste. So basically, the pressure is inversely proportional to the area, but it is directly proportional to the force. And the same laws that applies in physics around the arrangement of the resistance happens in our body. We have direct, or like they're going to be arranged in series, and the total resistance is going to be higher than, the sum of them is going to be higher than the individual. And this is basically happens as you go from the artery to the arterioles to the entire system. Whereas in parallel, they're going to be, the sum of them is less than the individual itself, because it's basically the reciprocal of it. And we have the function of having a parallel resistance is basically because you want to alter the circulation to one organ while not affecting the other. So for example, during exercise, you're going to re-diverge the blood from your intestine to your skin and muscles. If it wasn't in parallel, all of the systems would get affected. Okay, then the pulse pressure, those are like some formulas that you have to have in mind in order for you to understand. So pulse pressure is basically the difference between systolic pressure and the diastolic pressure. What's the systolic pressure?
Contraction.
Yes, it's the pressure that that's going to be within the blood after the left ventricle has ejected it. And the diastolic pressure, it's the minimum aortic pressure. Then I need you guys to pay attention to this point because we had some sort of confusion about it. How to calculate the mean arterial pressure? It's basically diastolic pressure plus 1/3 the pulse pressure, or it's 2/3 the diastolic pressure plus 1/3 the systolic pressure. Why is it 2/3 the diastolic? Because yes, the heart, it spends more time in diastole than in systole. Then you have this formula which talks about the major regulators of the mean arterial pressure, which are the cardiac output and the peripheral resistance. Make sure you understand which is for calculation and which is for regulation, because you could get a question that might ask you what are the factors that is going to manipulate the mean arterial pressure, and you could get cardiac output and total peripheral resistance as well as the pulse pressure, because it was a tricky point. So please just pay attention. Is the question asking you to calculate it or to manipulate the partial pressure? Because you have both formulas. In both ways, you're going to get the mean arterial pressure, but one is more concerned with the regulation while the other is just a calculation. Now, when it comes to the regulation of the mean arterial pressure, you want to keep it constant. But it's related to the cardiac output and the total peripheral resistance. If I want to keep something constant, if one variable increased, the other should do what to balance it out? Decrease. So in cases of an increased cardiac output, the TPR is going to decrease to keep it constant. Okay, and those two, those points are very important, because if, like, the question might ask you directly, what could increase one and what could decrease it? It makes much more sense if you understand it, but also keep in mind that you need to memorize these stuff. What are the major factors that regulate the systolic? Stroke volume. It makes sense because the larger the volume, the more the pressure you're going to have, and then the compliance of the arterial tree. If an artery becomes less compliant, the pressure is going to increase because it's going to become stiffer and less able to expand and accommodate. While the diastolic is the total peripheral resistance. So if you're going to pump against a very high resistance, it's going to affect them. And we just said that the pulse pressure is the difference between both. So these three factors will ultimately result in the alteration of the systolic pressure. Okay, now we're going to come with this question. A 53-year-old woman is found by the arteriography to have 50% narrowing of her left renal artery. What's the expected change in the blood flow through the stenotic artery? Stenotic means narrowing.
Oh, okay.
Yeah. Be careful at what the question is giving you and what he's asking you for. Okay, so he's saying that there's 50% narrowing. So if the vessel is normal, and I took 50% of it is obstructed, so you reduce the radius by what? Half. I'm asking you, what's the flow? Yes, the flow is going to decrease by what? 1/60, exactly. Because as the first time I was solving the question, I thought they wanted the resistance. But here they said they wanted the flow. So you basically have to link the resistance, how you change the diameter, link it to the resistance, and then see how it's going to reflect on the flow.
What's the answer?
D. Okay. Then, which component of the circulatory system, this is easy, contains the largest percent of the total blood volume? Veins. A decrease in which of the following is going to increase the pulse pressure? Take your time. You need something to decrease for your pulse pressure to increase. Now let's go through them. If you decrease the systolic pressure, will the pulse pressure increase? No. If you decrease the stroke volume, will the pulse pressure increase? No. If you decrease the compliance of an artery, if you decrease the compliance, you're going to elevate what? The systolic pressure. If you elevate the systolic pressure, you're going to increase the pulse pressure because you're going to have a higher number. So when you subtract the difference, the pressure is going to be higher. Okay? That's why I told you this slide is very important, because questions might come directly like that. Okay. That's it for the first lecture. We're going to move on with the control of the blood pressure. Yes, I cannot remember the question exactly, but it was basically he was asking you what are the major factors that you could regulate the mean arterial pressure.
So he's not talking about
No, but in the options, like you might get this method increase the systolic, decrease the diastolic, and then you would also have increased cardiac output, decreased TPR. But you need to make sure which ones are used for calculations and which one is used maybe for as a regulator. I can't tell you because maybe he will change, like things might change around. But just make sure that you read it carefully, and it's gonna get even trickier when I'm gonna talk about the second part, long and short-term regulations. Because there are things that maintain the blood pressure, there are values to calculate, and there are things that regulate it. Okay. The control of the blood pressure, we just talked about how to maintain it through the cardiac output and TPR. Then we all know that things can fluctuate, but we have a short-term regulation, which is something instantaneous. For example, if something that caused your blood pressure to suddenly increase, you're going to have a reflex that's going to tone it down. But if this increase or decrease in pressure was for a long period of time, you're going to have the RAS system, which is the renin-angiotensin-aldosterone system. Okay? So we're going to start quickly with introducing what's the constitution of a reflex. It's simple. You need to have an integration center, which is going to have a set point. This set point is going to be your reference number. So for example, you're going to compare the information that you're going to get from all around the body and see, does it match? Or is it lower or is it higher? Then you're going to have the afferent pathway, which takes the, or like, sends you the information, delivers the information for you. Then we have the efferent pathway. They're going to take the information that you have decided upon. Then the effectors, which could be the heart, the muscle, depending on the reflex. Now, the short-term reflex is going to be the baroreceptor reflex. This one, if we apply what we just said, its integrating centers are going to be in the medulla oblongata. The receptors are going to be these two, the ones that are present in the aortic arch and the ones that are present in the carotid sinus. The afferent one is going to be the glossopharyngeal by the carotid sinus, while the aortic arch is going to be the vagus nerve. They are going to transport these information to the medulla oblongata, and then based on the reference point, you're either going to get an activation in the sympathetic or the parasympathetic. Now, this graph on the right is going to explain to you how the firing rate changes from these receptors. Basically, your brain is going to understand one thing, which is the action potential. So depending on these, on the blood flow that flows through these arteries, these signals are going to differ. So this is the aorta, it's going to be close to the heart. If your heart pumps up the blood at a very, very high pressure, it's going to cause the stretch of these two receptors. And then they're going to send information to the brain that we were stretched and received blood at this pressure. Then the brain حيتصرف معهم. It's going to activate the parasympathetic. And you can see, as you increase the pressure, the firing rate is going to increase because it's an emergency. Your body is not usually accustomed to this high pressure. And then the opposite is going to happen. If those receptors were not stretched, they're going to fire less, and the brain's going to be like, there's something missing, because they usually have to fire around at a constant rate, and then it's going to understand that we're having hypotension. Okay, then this is how the brain is going to act in different situations. So let's just say they were not stretched. So they sent information to the brain. They were stretched. So they sent information to the brain, and no, we were extremely stretched. We received a very high pressure. It's going to go to this nucleus tractus solitaris, which is present in the medulla, and then it's going to compare to the set point, which is normally what? 120. If it's above, it's going to shut down the accelerators or the sympathetic and activates the parasympathetic, decreasing the heart rate, decreasing the contractility, trying to set back the normal point to its normal set point, which is 120. The opposite is going to happen. The baroreceptors are not stretched anymore. They're going to fire saying that we're not stretched, meaning we have hypotension. We're going to do the opposite. Turn off the parasympathetic, activate the sympathetic, increase heart rate, contractility, and the venous return, which is going to store back the cardiac output and the main arterial pressure. Okay, now this is what happens if you have a change in pressure over a short period of time. But if this extends and became long-term, you're going to have a system in the body that's going to interfere, which is basically the RAS system, which stands for renin-angiotensin-aldosterone system. It has multiple causes such as decreased sodium chloride in the distal tubule, decreased renal perfusion, and decreased renal sympathetic flow. Mainly, you're going to understand this better next semester, but basically when their kidneys are not receiving their blood, they're going to sense that there's something wrong and that the blood is diverted somewhere else. It's going to consider it as some sort of decrease in the pressure, and then the kidneys, from their juxtamedullary apparatus, they're going to release renin. Renin is going to convert angiotensinogen into angiotensin 1. Angiotensin 1 is going to be converted by the ACE enzyme into angiotensin 2, which is going to trigger a cascade of effects. It's going to trigger the release of aldosterone, which is going to increase the sodium absorption. It's going to increase the sodium hydrogen exchange, which is also going to increase the sodium, and wherever sodium goes, water follows. It's going to trigger the thirst centers, so you're going to consume water, and it's going to cause vasoconstriction. All these effects together are going to add up to elevate your pressure back to normal. And those were the major two regulations. Now we're going to go to the chemoreceptor reflex. The chemoreceptor reflex, we have two types. One of them are in the peripheral and one of them in the central. The major difference is their location and what they're concerned with. In the peripheral, they're going to be present in the carotid and the aortic body, while in the central, meaning in the brain, they're going to be in the medulla of the brain. However, what they're going to sense is going to differ. In the brain, they always say that the brain only cares about himself. So basically, they're going to mainly sense the arterial CO2 and the pH. And then accordingly, it's going to act. If we have an elevated level of CO2 in the brain, it's going to increase the sympathetic outflow, causing you to hyperventilate, increasing the peripheral resistance. They get their own blood supply. They're going to redivert it from somewhere else, even if they increase the total peripheral resistance in the body. Okay? While in the peripheral chemoreceptors, they're basically going to be associated with the partial pressure of oxygen. Okay? They're going to detect a partial pressure of CO2 and pH, but they're most likely sensitive to the partial pressure of oxygen. If it's decreased, they're going to increase the sympathetic outflow, increase the parasympathetic to the heart, and increase the ventilation, because you're retaining a lot of CO2, so you want to hyperventilate to blow it off, so you could restore it back to normal and increase.
But why you increase parasympathetic?
It's basically, they're kind of linked together. You're going to decrease the heart rate, but your hyperventilation will increase the heart rate. So at the end, they're going to cancel out each other. You're going to activate the parasympathetic, but throughout hyperventilating, you're going to increase your heart rate. So one is going to increase, one is going to decrease.
And they will cancel?
Yeah. Okay, now the volume reflex. The volume reflex are very important because they're basically mechanoreceptors that are present throughout different areas in the heart. They're most likely associated with the major veins such as the superior and inferior vena cava and the right atrium. They're mechanoreceptors, so they're going to be stretched if something mechanical increase, such as the venous return. So when you get a tremendous amount of blood returning back to your right atrium or vein, it's okay. You're going to stretch it. Okay, this stretch is going to activate those receptors, and this, based on the degree of stretch, whether it was less or more, you're going to have two different hormones. If it was an increase in volume, you're going to release the atrial natriuretic peptide. If it was, which is going to help you get rid of the excess volume that you have through decreasing the reabsorption of sodium, and then water is going to follow. However, if you have a decrease in volume or increase in the hypercellularity in the blood, you're going to release ADH, which is anti-diuretic hormone, which is going to help you retain more fluid instead of getting rid of it. That's it for the second lecture. Then we're going to move on to the final physio lecture, which is basically the control of or the regulation of the cardiac output. Before we start regulating, explaining it, there are some things that you need to understand, which is the stroke volume. The stroke volume is the amount of blood that you're going to pump out from the heart, and it's related to three major things, which are the contractility, the preload, and the afterload. Because we said that mean arterial pressure was cardiac output times the TPR. Now, cardiac output could also equal to the stroke volume times the heart rate. Heart rate is not something that we can control. It's mainly controlled by the autonomic, which is the sympathetic and the parasympathetic. Those two systems are going to regulate the heart rate. However, the stroke volume is influenced by these three factors, which are the contractility, the preload, and the afterload. Okay, so what do you think? An increase in the contractility would increase, would it decrease the stroke volume?
Will increase.
Increase. And an increase in the preload, which is, think of it of venous return.
Will increase.
Increase. And the afterload is the resistance decrease. Okay. So basically, we're just going to quickly go over them. Contractility refers to how strong the heart is going to pump a blood. If you increase the contractility, so the force of the contraction is going to pump up more blood, because if you have a weak contraction, a huge amount of blood is going to remain. However, if you have a very strong contraction, you're going to pump the majority of the blood and a minority is going to remain behind. Now, these two pictures are going to explain how contractility occurs. So basically, an action potential is going to come to the cardiomyocyte. They have specific structures known as the T-tubules, which is an inward invagination of the cytoplasmic, they're going to be very close to the sarcoplasmic reticulum. So when this action potential comes across, it's going to open the calcium receptors, which are L-type. Extracellular calcium is going to influx in, and this influx of extracellular calcium is going to bind to the rhyodine receptors. Those rhyodine receptors are present on the sarcoplasmic reticulum. They will cause the calcium to be released. So it's called calcium-induced calcium release, because the extracellular calcium induced the release of the intracellular calcium. Then cross bridges is going to happen, and the contraction is going to remain as long as you have enough ATP. Because the ATP is going to remain the troponency away from the binding site of actin and myosin. Once ATP is depleted, the contraction is going to stop, and the calcium that was in the cytosol is going to be pumped back into the sarcoplasmic reticulum using SERCA. SERCA is the name of the receptor, or like the channel that is going to pump it back, and the extracellular, or the extra amount of calcium that we entered, is going to leave through the calcium sodium channel or the calcium ATPase channels. And then this basically going to explain how the contractility is going to be affected by the sympathetic and the parasympathetic. The sympathetic is going to act on beta-1 adrenergic receptors, while the parasympathetic are going to be by the muscarinic receptors. One is going to activate adenylate cyclase, resulting in increasing the calcium, while the other one is going to deactivate it, preventing the calcium from entering, reducing the contractility. Okay, that's it for the contractility. Now preload. Preload is basically the stretch that is going to occur on the walls of the atrium or the ventricles after the blood has been pumped. So it's basically linked to the Frank-Starling graph, which I'm going to show you in a couple of minutes. But as a simple way to think of it, it's basically the venous return. In your slide, you're going to have like a couple of slides where it's going to tell you preload could be indicated by 1, 2, 3, contractility could be indicated by multiple stuff, as well as afterload. So we agreed that if you increase the preload through increasing the venous return, the cardiac output is going to increase. If you increase the afterload, which is having a higher resistance, you're going to decrease the cardiac output. Okay, and then we know that the stroke volume is the difference between the end diastolic minus the end systolic. The end diastolic is the blood volume that remains after, end diastolic is the blood volume after the heart has finished filling. And systolic volume is the blood remaining after the ventricle has contracted. Then ejection fraction is the difference between those both, and they're most likely going to be around 60. It could vary from 50 to 70%, and it's very important clinically because in cases of congestive heart failure, it could be a big indicator if the patient is getting worse or better. And then we know what's cardiac output. Now, Starling curves are the ones that are highly related or reflect the preload. Here is how our heart is going to operate normally, and then when you increase the exercise, it's going to shift to the right, upwards, because with exercise, the venous return is usually increased. However, from the normal, in cases of heart failure, because you lose the contractility of the heart, it's not going to contract as much as it used to be compared to the normal, so it's going to drop. And then this is basically the two graphs that explains the length tension. Basically, what the Starling curves reflect is basically you need to have the cross bridges at a perfect tension. If it was too low or it was too high, you're not going to get the maximum amount of contraction, because here they don't overlap because they're understretched. Here they're overstretched where they're not going to overlap with the cross bridges, but basically at this point or even before this point, you're going to have the maximum point of contraction. Then we came to the Laplace relationship, which talks about wall tension and wall stress. It's basically a way of explaining how when you're going to increase the pressure, this is stress, which is basically the pressure times the chamber divided by the thickness. So because when pressure is going to increase, the stress on the heart is going to increase. As a compensatory mechanism, the heart is going to thicken. When thickness is going to increase, the stress is going to decrease, but other factors could vary. Then we have the cardiac output using Fick's law and the oxygen demand. If you're asking something to work harder, you're going to expect it to increase its oxygen demand. So increasing the cardiac output will ultimately increase the cardiac oxygen demand, and you can calculate it using this formula. So cardiac output is going to equal oxygen consumption divided by the pressure of the oxygen in the artery minus the vein. They would usually give you the cardiac output, ask you to calculate the oxygen consumption, or vice versa. And then here we have a question. So if we have cardiac catheterization is performed on a 39-year-old man who presents with angina, the left ventricular pressure volume curve shows a decrease in stroke volume and ejection fraction. Which of the following mechanism may compromise the stroke volume following myocardial infarction? So you have a decrease in the stroke volume, which is going to compromise following the myocardial infarction. Is it a decrease in the arterial pressure, decrease in the total peripheral resistance, increase in the central venous return, increased heart rate, or the sympathetic? We're talking about the cardiac output. See? You have decreased stroke volume. So you want to increase the cardiac output. Yes, so you would want to increase, yes, the heart rate to maintain it. And then in resting adults, what's the typical ventricular ejection fraction? 60%, yes, it's D. Okay, and then sympathetic stimulation of the heart normally causes which condition? When you have sympathetic stimulation, acetylcholine is with parasympathetic. Yes.
Increased force of contraction of both ventricles.
Yes, it will be D. Now we're going to quickly go over biochemistry because it's quite simple. So basically, cholesterol has a crucial role in the structure of membranes, and you need to synthesize it. Cholesterol could be synthesized de novo, or you can synthesize it from external sources such as your food. And then it's a very long process, but basically you need to memorize a couple of steps that are important. So you're going to start with two acetyl-CoA that are going to be combined together to form aceto-acetyl-CoA by thiolase. Then aceto-acetyl-CoA is going to be converted by HMG-CoA synthase to HMG-CoA. Then from HMG-CoA, it's going to be converted into mevalonate, which is the rate-limiting step, regulated by the enzyme HMG-CoA reductase, which needs NADPH as a cofactor. Now, because this is the rate-limiting step, it is the step that is going to be regulated. We have short-term regulation and long-term regulation. The short-term regulation is that when this enzyme is going to be phosphorylated, it's going to be inhibited, and this phosphorylation happens when you have high levels of AMP. When do we have high levels of AMP?
When you have low ATP.
Yes, when you have low ATP, it doesn't make sense for you to start synthesizing cholesterol when you need energy. Then long-term regulation is by a form of degradation or deformation. If you remember, so basically when we get mevalonate can act as a negative feedback, and it can inhibit further synthesis of cholesterol, saying that we have enough cholesterol. And the HMG-CoA reductase, it has a sterol sensing domain. This domain, it could be degraded by the enzyme proteases. So those are the two degradation. Now, moving on to the lipoproteins. Lipoprotein is a combination of lipids and apoproteins, which are the unfunctional form if they are not combined with the lipids. Once they're combined, they turn into their active form. What is important for you guys to know is the different types, where do they come from, and what is the principal function. So like what type of lipids do they carry, triglycerides, cholesterol, and where are they synthesized. And then you can see as you go from chylomicron to HDL, the size is going to decrease, and as you go from chylomicron to HDL, the density of the proteins is going to increase. So you need to know which one has the highest protein, which one has the highest cholesterol, which one has the highest components of carbohydrates, and also know what type of proteins, apoproteins, they're going to contain. Because only chylomicrons contain ApoB48, which is important for its recognition by the liver. And then some of them are going to contain C, some of them are not. So those are important things to look out for. The most important thing is the life cycle of each one. So quickly, chylomicron is going to be produced by the intestines. Then they're going to be, they're only going to contain ApoB48, which can hint that we're talking about chylomicron because it's the only one that's going to contain it. It's going to meet with its friend HDL, which is always going to donate to all of the other lipoproteins with ApoC2 and ApoE. ApoC2 is important because it's going to help the triglyceride, the fatty acids, get recognized by the lipoprotein lipases for the triggering of the lipolysis. Afterwards, it's going to return the ApoC2, gets picked up by the liver through the ApoB48. And then the same thing goes for the VLDL, which is basically going to leave the liver as VLDL, but it's going to come back as LDL. Because basically, VLDL is going to meet with HDL, gets the ApoC2, then it's going to be acted upon by lipoprotein lipases, and that's going to get converted after the lipids have, like the free fatty acids and the triglyceride leave, it's going to become ILDL. When the IDL is going to lose its ApoC2 back to HDL, it's going to be the LDL. Then the LDL is going to be picked up by the liver. So it starts as VLDL but comes back as LDL, and each one is going to carry different things. So you need to keep in mind which one contains the high amount of cholesterol, which one has higher triglyceride. Then the LDL is going to be picked up by the endocytosis by the liver membrane, and then based on its cholesterol content, it could either stimulate the production of cholesterol or it could inhibit it. Because if it has a high amount of cholesterol, this is going to act like a negative feedback and inhibiting further cholesterol production. The HDL metabolism is going to be, basically it's the one that always donates the ApoC2 to the other ones, but it's going to start as a nascent, then it's going to start accumulating and collecting cholesterol from the peripheral tissues, then it's going to give it to the VLDL, LDL and all of these stuff. Just keep in mind which are the active form, which is the HDL2, this one is still inactive, and keep in mind about these two enzymes, the LCAT, which has similar function but in different organ. What is it called? Yes, the ACAT, which is in the liver. LCAT is going to be in the periphery. Both of them are going to convert cholesterol into cholesterol esters, which is their storage form. Then we have the cholesterol ester transferase is going to pick up the cholesterol esters from HDL, give it to the VLDL and the LDL. Then this is very important. I think the doctor warned you about it. You could expect a question from this. This is the table that was in our PowerPoint, but this is from the USME. It's much more helpful because it gives you what specific pathogenesis is going to be missing. So the question might describe, I'm going to show you a couple of questions, that there was a defect in ApoC2. So what is going to be the clinical presentation? Or the question might describe pancreatitis. So you know which one to put in mind. Also keep in mind that if the question describes the plasma looking milky, we're most likely referring to chylomicrons, and chylomicrons are not going to be found in blood after 12 hours of fasting because they're usually going to get released from your stomach after you consume a high amount of fatty meal. Now, which of the following best describes the role of cholesterol transferase? It's C, because it's going to exchange cholesterol esters from HDL. Now this is like a classic presentation. A young girl with a history of severe abdominal pain was taken to her local hospital at 5 a.m. Blood was drawn and the plasma appeared milky. This is going to give you a quick hint that we're talking about chylomicron. Which of the following lipoproteins are the most likely responsible for the appearance of this plasma? Chylomicron.